Okay, so starting treatment. We're going to work on the starting of treatment now. The first three parts of starting treatment are to make a case formulation, to do psychoeducation with the adolescent and the parents, and to do your first session, which sometimes takes 2 sessions, but involves setting goals and having a safety plan. Okay? Now, how many of you use a case formulation in your daily work? Do that? Some, okay. Okay, my guess is that that the rest of you are using an implicit case formulation, that you have some idea of what you're doing and why you're trying to do it, right? I mean, I always have a well-articulated, case formulation. But the case formulation is the way we understand what it is we're trying to do and why we're trying to do it with this particular person, okay? So when we were doing the TAD study, the way we tried to assure that clinicians did this is we asked them to do a brief case formulation at the beginning of the treatment, and then after 6 weeks to send in a revised case formulation with a plan for what to do later. So the case formulation is kind of an ongoing process. You don't just do it once and then, it never changes. But these are some of the things that you look at for your case formulation. What is the biological vulnerability of this person to get depressed? Okay, so this is where you use that developmental and family history. Is there a family history of depression? Is there a family history of bipolar disorder? Was this a child who was always introverted and kind of withdrawn or not? Okay? So you look at that. Then you look at learned behavior, things they have learned over time that are influencing the way they cope with the stressor they're dealing with right now. So you're going to look at behavior they've learned by reinforcement or by association or by modeling or social influences, and then you're going to look at cognition, the way they think. Okay? Their expectancies, their attributions, their biases, and so forth. So we can't do anything about genes, but we can target the learned patterns of behavior and thinking that maintain the depression. That's what we're going to try to do. So this is what I would recommend you ask yourself about when you're thinking about a case. In terms of learning, has this depressed adolescent avoided potential sources of pleasure or positive reinforcement? Are they overgeneralizing from one negative event or situation? Are their parents or siblings also modeling depressive behavior or thinking? Any of those things can become part of your case formulation, your treatment targets, okay? Are they having problems in peer relations or parent-adolescent conflict? If there's parent-adolescent conflict, then we have family modules that help to deal with that. All right, so let's look at these little examples I gave you earlier and try to figure out how to apply these things to those cases. So the first case was a kid who's walking down the school hall and sees a girl that he likes and says hello to her, and she says nothing to him. He may have an expectation that girls will not like him. He may have an automatic thought, she ignored me. He may have a dysfunctional attitude. Unless she pays attention to me, I can't be happy. He may attribute this to something wrong with him. She ignored me because I am boring. And he may have a core belief that I am unlovable. I don't know, of course, at the beginning whether he has any of these things, okay? I'm just guessing at it. I'm going to come back to this later. We can get the manual online. You have this. If you ever want the manual, this is where it is. And if you don't want to remember that long line, you can just Google TAD CBT Manual, and it'll come up. The point is that in this treatment, we're going to use a modular approach where we pick modules to address the things that come up in the case formulation. Okay? The CBT addresses individual and family factors that are relevant for most depressed adolescents and for this depressed adolescent. Okay? They're core treatment modules and optional treatment modules. So here are some possible targets for the treatment. Is the adolescent behaviorally withdrawing? Are they lacking involvement in pleasant activities? Are they lacking social interactions? Are they being too passive and non-assertive, so they're getting kind of pushed around and then getting down on themselves? Do they have poor problem solving or depressive thoughts? You have no doubt seen kids with affective dysregulation. They seem to do really well in the session with you, and then on Saturday night you get a call that they're in the emergency room, they just tried to cut themselves, okay? So that's what I mean by affective dysregulation. They get so overwhelmed by the emotion that they forget all the skills they learned. If that's there, that has to be addressed too. And anxiety. Does the anxiety keep them from involving themselves with people, okay? Okay, so those are the individual treatment targets that you might have, and then there are family factors in adolescent depression. These are some things that you might see in an individual case. So if you see it, it goes into your case formulation. Is this a kid who has parents with excessively high expectations, so that a grade that's not an A is a terrible thing? I've actually seen more kids who have this than parents who have this, but sometimes they get it from their parents. Now, more likely is low rates of parental positive reinforcement. Are the parents just not giving the kid much positive feedback? Or do they have poor problem solving themselves? Or do they engage in a lot of yelling and screaming, which is called expressed emotion? Okay? Are they hostile and rejecting or less warm? These are not things that are typical in most families of depressed kids. They're just things to look for in a given case, okay? Do they have ineffective parenting practices? The things that we heard about in the talks yesterday for disruptive behavior disorder sometimes occur in depression or in depressed kids who also have oppositional features. Do the parents not know how to set limits and discipline? Is there a lot of parent-teen conflict, more than normal? Okay. So one thing that sometimes confuses people is that this version of CBT is a combination of required components and optional components. And the required components are required because they're useful with almost all depressed adolescents. Almost all depressed adolescents. But even so, in your practice, you wouldn't be required to use it. You're not in a clinical trial. You don't have to do what everybody at all the other sites are doing. So you may find that there are some parts in the so-called required modules that you don't really need to do based on your case formulation. So it's a little different from a treatment program in which you just step through a manual and everybody gets the same thing, okay? There's some of that in it, but there's also some individual tailoring, and it's hard to, that's one of the things that's a little hard to get a handle on in this approach. But I do try to emphasize the case formulation because it's the way you answer for yourself this first question: why is this adolescent depressed? Okay? And what we asked the therapist to do in the study was to just jot down what they thought were the factors in the adolescent or in the family that were contributing to her or his depression. So what individual factors, what family factors. And then we asked them to say what skills they thought the adolescent needed to learn or the family needed to learn in order to cope better with stress so they didn't get depressed or they could kind of pull out of the depression. And finally, what strengths does the adolescent or the family have that they can build on in treatment? The way the case formulation went in the study, and you can adapt this to your own practice, but I think this is a pretty decent way to do it, is that there's an initial case formulation that you write up. These are very short. They're like 2 paragraphs, right? You write up after you've done your assessment. And the TAD CBT probably should be thought of as an 18-week treatment. You saw the results yesterday. The results are much better at week 18 than week 12. So I think of it, when parents ask me how long is the kid likely to be in treatment, I say somewhere between 12 and 18 weeks, 16 weeks, something like that. But I think of it as this is not the fastest treatment for depression in the world. You could see that on the slides, right? And it just takes time. It's like Bill was saying, that these behavioral interventions take time because they involve learning, and that takes time. You just think about how hard it is to learn, some other skill. You try to learn a language, or you try to learn to play a musical instrument, or you try to learn a sport. It takes time and practice, and that's the kind of analogy to use here. So anyway, given all that, what we recommended to the therapist was that they did a baseline case formulation, a week 6 revision. At week 12, they kind of took stock of what was working and what was not working for this kid, and then they used that to plan the next 6 weeks. And then at week 18, they reviewed with the adolescent and the parents what seemed to have helped, so that they could then rely on that going forward after treatment ended. Okay? And we're going to talk about relapse prevention toward the end of the workshop.
So the other 2 things are sort of more questions and one sort of provocative one. What's your thought of self-report versus other report? So like the Children's Depression Rating Scale is the clinician's assessment of versus the person's own experience of.
Yes.
And then sort of the second one's a little provocative of, there's a wonderful website I've been reading lately of Psychotherapy Brown Bag. Why should we even have objective questionnaires? What do they add to the clinician's judgment? So
okay. Oh, well, that is provocative. Good. That's better than coffee. I really got it. Okay. So self-report versus other. This is a really important question in child work, especially anxiety and depression work. In general, I like to rely on what the kid says. If I have a discrepancy between the parent and the kid, when it's a question of a mood disorder or an anxiety disorder, I tend to give predominance to what the kid says. So if the kid says they're having a problem and the parents don't see it, that may just be what it is. The parents may just not see it because it's an internalizing problem. Now, on the other hand, the parents can see some things that the kid may either deny or not be aware of, like psychomotor retardation, or I've never really had kids deny sleep disturbance, but theoretically they might deny it and the parents might notice that they're up all night. So I do take both into account, but if there's a conflict, usually go with the kid. I think I mentioned this to somebody yesterday, not in the talk, but we had this kind of debate in TADS whether we should take in kids who denied depressive symptoms. In other words, should we take them in if only the parents say they have it? Well, as a CBT therapist, I didn't want to do that. I didn't want to take them in if they said they had no depression, because what the heck would we do with them in psychotherapy if they said they had no problem? But I lost the argument. Lost a few arguments in TADS, but that one I lost because Graham Emsley was the one who argued that we should take them in because they may be in denial, and the parents may see real things, and if you're convinced, that the parent is accurate, then you have to treat the depression. And this might be an area where medication would have an advantage over psychotherapy. Might not. So we did take them in. I don't know if we had very many I don't know whether we had people that denied it up and down the line. I mean, we certainly had cases where the parents reported more than the kid did. What's the value of objective questionnaires? This is a great question. So the clinician's judgment. Now, I am a clinician first and a researcher second, so I always make that clear to people. I did lots and lots I still do clinical work every day, almost every day. Not as much as you do. I don't see as many patients as you do if you're working in a clinic or a school, but I see a couple patients a day on most afternoons. So I think clinicians are great. I think clinicians are marvelous people, but I can get faked out. So the value of an objective questionnaire is that it kind of forces me to take a look at something outside my own intuition. It's a check on my intuition, and so that's where I see the value. Now, of course, in research, they have the value that they can be quantified, and then you can look at outcome and stuff like that. But in clinical practice, they're valuable because they act as a check on my intuition. And sometimes kids will endorse items on a questionnaire that they won't endorse in the interview with me. They're more shy about it, so they put it on paper. And Achenbach's got a whole line of research on this issue of discrepancy and what it means. So I use the Achenbach routinely with all my patients, not just depressed adolescents. I mean, I give the parents an Achenbach child behavior checklist, and I give them that developmental history, almost in every case. And then that gives me a lot of, it covers the waterfront, so if I'm missing something, it's going to show up on there. So I do like that very much. One of the participants asked me if I actually do all three of these interviews that I showed you, like the unstructured interview, the diagnostic interview, and then the rating scale interview. I don't typically do all that in a routine clinical case. I always do the unstructured interview and one of the other two. We did all three in the research study, but when you're doing a research study, you're getting paid to do the research, so and the patient is getting compensated to some extent for time, so time is not as much of an issue as it is in a clinic. So you just can't do all this stuff in a clinic. You pick the things that you think are going to be the most advantageous. Okay? All right. Anything else on that? Because those are really assessment questions, so this is a good time if you have other assessment questions to bring them up. I would say the core thing you must do to assess depression is an interview, an unstructured interview, some kind of symptom review interview, and a self-report scale of depression. And you have to look at other things because of the comorbidity. So you should use an Achenbach or something broad, or a broad self-report like a Milan. I have not used the Milan, so I don't have an opinion about it. But something broad like that, to see if there's anxiety or disruptive behavior or oppositionality or substance abuse, because they're so common among depressed kids that you have to ask about them. And you have to screen for bipolar disorder. Now, when I talk about bipolar disorder, I mean it in the strict sense of the DSM-4, like the symptoms of mania. Not whether this kid, has temper tantrums. To me, that's not bipolar disorder. So I'm talking about elated mood, grandiosity, extremely poor judgment, kind of wildly impulsive behavior. We had a kid on the inpatient unit who was hospitalized for mania, and his presenting problem was that he had stolen a car in Chapel Hill and driven to California. That was true. He was manic. He was really, really manic. That's what I mean by manic. Okay. So I use a high threshold for mania. You really got to meet the criteria. Any other things on assessment? You can always bring them up later, but I'm just saying if you have questions now, this would fit. Because assessment leads to case formulation, which guides treatment. All right, so let's look at this case formulation. Now, just look at this, this slide and the next one that I'll show you. So this is a made-up case. Mary's the oldest of 5. Her father is alcohol dependent. There's a lot of parental conflict at home. She was a rather shy, inhibited child who avoided competitive games, focused more and more energy on her schoolwork. She became depressed when she failed math in high school. So that's why you're seeing her. She withdrew from her friends and spent more time alone in her room and started to have trouble sleeping and eating. Her parents worried about her and urged her to go out. When she refused, they then got angry at her. Why is this kid depressed? What are your speculations? Just brainstorm for a minute. What are some things that might be contributing to her depression? Don't look at the rest of the slides yet. Right. She doesn't feel successful. In fact, she probably feels like a failure. Why?
Well, she may be catastrophizing, but she's not good at anything.
Okay, so she may be catastrophizing. She may be way overgeneralizing from one failed course, right? Why might she have gotten into that?
Because of the family and she focused and invested everything.
Right, because she's so invested in this one thing, okay?
A failure means failure
Right.
everywhere.
So her self-schema is very narrow. It's all about school, okay? Family factors? We already talked a little bit about family factors, but what other family factors do you see in this little vignette?
Alcohol,
Okay, so you have an alcohol-dependent parent. You're going to have to decide if you're going to do anything about that. Just hold that thought. What else? Conflict, parental conflict. You have to decide if you're going to do anything about that. And then at the end, they're worried about her, so they're getting on her case. And she's refusing, and then they get angry. So that you probably need to do something about, because that's immediately part of the current dynamic in the family, right? Now, with regard to substance abuse or psychopathology in the parent, it's not part of the TAD's treatment to treat it directly. So we would typically refer people for that. We would point it out at the appropriate time, whenever that is, and refer the father for help with that. But there's nothing in the TAD's manual to treat parental alcoholism or parental depression, okay? And, we talked a lot about this issue yesterday. It seemed like almost every talk dealt with this issue, whether you should focus narrowly or broadly, And if you focus too broadly, you're going to lose your focus. And if you try to do everything, you're not going to end up doing anything. So I've gotten to the point where I'm more inclined to really try to hone in on the depression and then do what else I can, but not lose focus. Right? How about temperamental factors? Any reason that this kid became depressed as opposed to oppositional or conduct disordered? She was a shy, inhibited kind of kid, more prone to an internalizing disorder than an externalizing disorder. I can't do anything about that. I can't do anything about her temperament except help her to, make the most of it. It's not a bad temperament. It's just different, right? Different from an oppositional kid's temperament.
Do you think gender has to do something with it? Because the boy in this equation should have ended up with more externalized behavior?
It's more likely, yeah. The probabilities are that there are more boys with externalizing problems than girls, and there are more girls with internalizing problems than boys. So the same scenario might have led another kid to become oppositional or angry. Could be a boy or a girl, but the base rates are higher for that in boys, whereas the base rates for the depression are higher in girls. So gender could be playing a role. Okay? So, whoops, I don't know why that thing keeps coming up. So, these are some of the things that I thought of when I was making this up. It may be that there's also a lack of parental nurturance because the parents are in a conflict, so they don't have a lot of energy for the kid. I don't know, that wasn't really clear in the blurb. Narrowing of her interests we talked about, self-schema, overly focused on academics, and the catastrophizing dysfunctional attitude. If I do not do well in school, I am incompetent. If I do not do well in this course, I am incompetent in school. If I do not do well in school, I'm incompetent. Okay. Maybe this is a possibility when you have kids whose parents are in conflict. They may be reluctant to talk about problems with their parents because they don't want to burden them. Now, this would be where, you know, I would be really interested to see if the attachment-focused family therapy would focus on this, you know. That Guy Diamond work is to get kids talking more openly to their parents about their problems. And if there was a blockage like this, then it could be pretty directly, but you could do it in CBT as well. And then behaviorally, she's withdrawn, not doing things, and that's increased her conflict with her parents. So that's the part of the formulation about what factors in the child and the parent are leading to this kid's depression. And then you turn around and say, now what skills does she need to learn in CBT? Increase pleasant activities, even when you don't feel like it. Of course, this is the hard part of doing pleasant activities. You have to help people to do things even when they don't feel like it, because they're going to feel better after they do it, right? Have you ever had a time when you were supposed to go to a party and something bad happened during the day and you just didn't feel like going to the party? I mean, I've had that happen a couple times. So I can either just, you know, sulk and stay home and, you know, kind of wallow in that, or I can go to the party. Now, I know darn well I'm going to feel better if I go to the party. I know it. Absolutely know it. Okay? I don't know if I always do that, but I mean, that's what you're supposed to do. So pleasant activities is to do it even if you don't feel like doing it, because you will feel better after you get involved in it. Increase social interaction, and then the cognitive part is, you know, check out the reality of these thoughts. Is it really that terrible that you failed this course? Does it really mean you're totally worthless? Use some problem solving to cope with the failure. Okay, given that you bombed that course now, what else can you do? Take a summer school course, get tutoring, I don't know, whatever, you know, problem solving. And then work with the parents to reduce parent-adolescent conflict. We'll talk more about that as we go through. This kid has a lot of strengths, so it's good to put these in your case formulation so you don't get myopic and only focused on the negative. She seems to be intelligent. She's got parents who are basically supportive even though they have their own problems. Her social skills seem to be intact even though she withdraws. I mean, she's able to talk with people. She just isn't doing it. Okay? So that's one case. Now the second case, this one is close to a real case. It's a little bit changed, but. So this is the boy who's the younger of two brothers, and his mother suffers from intermittent depression, which was quite severe when he was a child. So this is a kid whose mother was depressed when he was little. He seems emotionally closer to the father than the mother. He has a pretty significant learning disability that makes schoolwork very difficult. He has poor verbal communication skills. His depression was triggered by a breakup with his girlfriend, which took him completely by surprise. And he made an impulsive suicide attempt. It was an overdose. This is true. I mean, this is exactly what happened. This kid made an impulsive overdose with his mother's medication after this breakup. His parents are quite frightened and anxious. All right, so let's not look at the next couple slides. What factors in the child or the family are contributing to this kid's depression and suicidality?
Biological factors?
So there's a biological factor that his mother has a history of depression, so that, increases the risk that he would get depressed compared to somebody who doesn't have any family history. What else?
How about the modeling, like express
Modeling. So he has seen depression, and he may have learned it by modeling, right? That's good. Good point.
Could there be some problem with attachment with mother as well, because he wasn't very attached to the mother?
Right.
That
And-
resulted in social skill deficit as well
Yeah.
and other problems.
Yeah.
And
His-
then
yeah.
Another rejection, another female figure.
Another female, yeah.
Triggered, and he actually responded to
Yeah.
that.
It's tough being a guy, right? I love to say that. I love to say that in faculty meetings. It's really fun. Anyway, yes. But no, it's true. Female rejection triggered. Yeah.
You mentioned that he has a learning disability and poor verbal
Yeah.
communication skills. I wonder about his ability to have insight.
Right.
or be able
Right. Or even do the treatment, right? Right. So you're up against it here if you're doing psychotherapy. Remember now I'm beginning to feel old because nobody got my Albert Ellis joke yesterday, but even older than that was the Yavis. Anybody remember Yavis? This kid is not Yavis. Young, attractive, verbal, intelligent, right? And successful. Those were the people that we tried to get into psychotherapy because they would be the most likely to benefit from it. Okay? That seems like 100 years ago. But this kid is not Yavis. He's young, attractive, but not verbal. His intelligence is okay, but he's not verbal. And he has not been successful. So as a psychotherapy candidate in the old-fashioned sense of the word, he's not the best candidate. You're going to have to do something about that if you do CBT. Okay? What could you do about it? Behavioral would be probably more effective than the cognitive stuff. I wouldn't say he can't do cognitive. Let's see if he can do it. But on the basis of what I've seen so far, I'm probably going to get more bang for my buck if I emphasize the behavioral part of the treatment. Right? Okay?
Some skills training.
Yeah. And I'm even going to have to work at helping him monitor his mood and be able to label his feelings because his verbal skills are well below average. All right. So I wrote down these things here. More nurturance from father than mother. His father always brought him to the sessions. His mother did come once, and she was a nice enough person, but there was some kind of a distance there that probably went back to childhood. His parents were not critical. They were nice people, but they weren't very rewarding. They didn't give him a lot of praise. His pleasure derived mostly from social interaction and not from academics. You've probably seen kids where that's the case, right? Verbal communication deficits, I think, actually led to his lack of awareness of how his girlfriend was feeling. When you went over this with him later, there were pretty clear signs that something was going to break here with the girlfriend, but he did not pick up on them. He just wasn't communicating with her. And his dysfunctional attitude, I would hypothesize, is if she rejects me, I am worthless and unlovable. His suicide attempt was impulsive. There were a few other things that he had done that were impulsive. I wouldn't say he was a real impulsive kid, but he had some instances of impulsivity. And his parents became very scared, so they were like, whoa, what are we going to do? That kind of thing. So they needed some assistance. So skills to learn. What is it I'm going to put in my case formulation treatment plan? Affect regulation. This is an impulsive suicide attempt. He was overwhelmed by affect and he did some self-harm. Okay? So I have to put that up front. I may need to deal with that first in the treatment because it's urgent. The Marshall Linehan stuff on, was it life-threatening behavior, therapy-threatening behavior, skill deficits? You kind of orient what you do in terms of urgency, okay? Another thing that helps kids who are impulsive or make suicide attempts is problem solving. People make a suicide attempt when they cannot resolve a problem. They can't think of any way out of the box. So teaching them to be more flexible problem solvers is a reasonable thing to do. On cognitive work, if I can get him to do cognitive work, the belief that this is the only possible girlfriend in the world. We actually did get to this. He was okay eventually getting to this. That she's not the only possible girl he could ever have a relationship with. And at a deeper level, the schema of I am unlovable. We got to that a little bit. It takes a long time to get to that level. Increased peer interactions. Fortunately, he played the guitar, and he had a friend who played drums or something, or another guitar. So he would go over to the friend's house, and they would play music together, and that was one of his favorite pleasant activities. And then increase the parents' understanding through psychoeducation. His strengths are that he did have some interests, that his parents were committed to him, and in school he had a pretty good individualized education plan. The school was doing a good job. This kid lived in Wake County, Raleigh, and his school was on top of things as far as the IEP, I thought. All right, so I don't think I need to go through all of these slides, but yes?
To increase affect regulation.
Yeah.
Could you give me some examples of what you do?
Yes. Step one is the mood monitoring, which is to help them understand the feelings, the intense feeling they have that leads to a problem. Now, it might be a feeling of anxiety or a feeling of anger, or, I don't know what the feeling is. I'd have to ask him. But once I get a handle on what the feeling is, then I'm going to give him a thermometer, an emotions thermometer that goes from 0 to 10. This is going to be covered tomorrow or some too. And I'm going to ask him, like, okay, so let's say that you made your suicide attempt when you were intensely angry. Is that the most angry you've ever felt, or have you felt more angry than that ever in your life? And whenever is the most angry he's ever felt in his life, I put that at a 10. That incident is a 10. And then I'll ask him some stupid question like, how angry do you feel when you're eating ice cream? That's a 0, okay? And then we say, now, how angry, can you think of a time when you felt angry at about a 5? And you look around for other examples. And you try to fill out at least 3 or 4 numbers on this 0 to 10 scale, so that he gets the idea that anger is an affect that has a range of intensity. And then you say, okay, when you made this suicide attempt, at what point did you lose control? I mean, at what point on your anger thermometer did you lose control? Was it a 7? Whatever. That's called the boiling over point. So we need to help you learn to do something before you get to 7. At what number do you notice that you're starting to lose control? Well, maybe it's a 5, okay? So we call 5 the action point. This is all going to be, it's in the slides for tomorrow, but I'm going to just, so you don't need to worry too much about writing everything, but 5 is the action point. So when you feel that you're up to a 5, you have to do something. Then the question is what to do, right? So you got to figure out with him what he can do to calm himself down when he hits a 5. Now, some examples that kids have done with me in the past are call somebody on the phone, some of them talk to their parents. Some of them take a walk. Some of them go distract themselves by listening to music, okay? I want to find some simple activity that he can do to calm himself in the moment. And then I want to involve the parents in the session so they know what that action is. It has to be done openly with the parents. You can't do this secretly between you and the kid. That's a disaster. The parents need to know what the plan is. Of course, they need to know about whatever suicidal risk there is, which they already knew about. And then they have to be able to help the child to implement the plan. That's a very simple, single method for affect regulation. It was really the only one in the TADS manual. Now, if you know dialectical behavior therapy, you have a whole other range of things you can add in. So, you know, in Linehan's DBT, there's an entire, I don't know how many sessions it is, it's a lot of sessions on emotion regulation and things you can do to regulate your affect. And it ranges from like holding a ice cube in your hand. It's one thing that sometimes helps people. Anybody know other things in DBT? Do the opposite of what you feel like doing. Right. There's a whole lot of them. Now, that's not all in the TADS manual, but it was included. Some of that was included in Tordia because they had more of these kids, and they had to have more affect regulation stuff in their manual. The basic idea is teach them to monitor the way they feel, notice when they're starting to get out of control, and take some action to calm themselves. Just going to ask you to repeat that so we can get it on the video.
My question is with regard to skills to learn, like testing the schema. I'm not lovable, I'm unlovable.
Yeah.
And because he has this learning disability issue, is that become a challenge? Because we also know that he doesn't have a good attachment pattern with his mother. So when you work on that, he hasn't really learned to have good positive schema. And now we are trying to test that.
Yeah.
So for him, maybe it's a reality that I'm not lovable. He hasn't been loved by the first caregiver.
Yeah, well, I guess the first thing I would think of is that's a long-term treatment issue, so that getting him out of his acute depression or his suicidal risk, I can do that without totally getting into that. Now, once you get into it, which you would if you were going to see him for a while, you know, I would use one of the family modules that we have, although it's a little risky, but it's called Rekindling Attachment. It's in the manual, and we'll talk about it tomorrow, where you try to get the parents and the child to kind of recollect when times were better and reestablish their positive feelings toward each other. Now, I say it's risky because I don't know how this mother really feels. So I would see her individually first to size up whether this was a good idea, right? If it's not a good idea, I'm not going to do it. And I'm just going to go straight cognitive and say, well, if your mother wasn't able to do this, why wasn't she able to do this? Was this because something was wrong with you? Or is it because your mother was in a depression and she was unable to be available, which doesn't have anything to do with you. I mean, it still feels bad, but it's nothing for you. And look at these other people that do love you. Your father obviously loves you. Your mother loves you enough to come to sessions and to, cooperate with the treatment plan. You have friends who love you, and I would look at all that stuff. So tomorrow morning, we're going to talk a lot about cognitive restructuring, and there are several methods in cognitive restructuring that you can use to do this. Now, do I believe that just pure cognitive restructuring is as emotionally powerful as an actual family rekindling? No. I mean, it's hard. It's hard. You have to kind of convince yourself of it as you're the patient. So it takes longer, and it takes a lot of perspective taking. I mean, how old do you think a kid would have to be before they could understand that their mother didn't show them much affection because their mother had a limitation? It takes time. I mean, what, 30, 35? I mean, so he's like 18 or 17, so I'm not going to keep him in treatment until he's 30, but I'll do the best I can, but I think developmentally he's going to have to come to that his mother really had limitations. Okay. Now let's see. So we talked about the spiral. Now this is just an application of what we've been talking about. In the case of Mary, this is her downward spiral. We talked about that. So we're going to try to disrupt this spiral by changing cognition and behavior and how she reacts to emotion. Okay. Okay, basically sequence of the treatment is first to establish a relationship and do psychoeducation, set goals, and teach mood monitoring. The second phase, which is this still in the first 12 weeks, is to keep building the relationship, do the behavioral activation, problem solving, do more psychoed with the parents. Third phase is the cognitive restructuring, and then you plan the rest of your treatment. Okay, so